This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to give an overview of our free program for those attending for the first time. So we'll discuss who we are, what is our program, some upcoming events, introduce our speaker this evening, Jan Dommerholt, and then we'll have a Q&A. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, who is on the call, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife, Carol, passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We also have been a sponsor at these conferences for the last 5 years. We've started over 100 groups to date. Each group is given their own free website and a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities, but many cannot afford physically or financially to attend in person. So we decided to bring to you the speakers through the free EDS Awareness Educational Series. We typically meet every first and third Tuesday at 7:30 p.m. Eastern Standard Time. All of the programs are free. The meeting announcements and whenever possible, the recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free guide on our site. Tonight's presentation is sponsored by Body Sports Store, where you'll find over 250 products selected by EDSers for EDSers. The store is the only funding for this program, and it usually covers our monthly web fees. Please visit our store and check out the helpful products that we offer. Just a general disclaimer. This presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911 or the emergency services in your location. Always consult your doctor before making any changes to your treatment.
And for those attending live tonight, there will be an opportunity for Q&A after the presentation. Add your questions at any time by clicking the Q&A icon at the top of your screen. After typing your question, click the orange button to submit. Our speaker tonight is Jan Dommerholt. Jan is a recognized expert in the field of physical therapy, diagnosis, and treatment of persons with chronic pain syndromes, including EDS. He is the owner of Bethesda PhysioCare in Bethesda, Maryland, co-owner of Physio Fitness in Rockville, Maryland, and the owner of MyoPain Seminars, also located in Bethesda. He has taught many courses and lectured at conferences, including EDNF, EDS Society Patient and Physician Conferences. He is also a recognized expert in the PT diagnosis and treatment of persons with myofascial pain syndrome, chronic pain syndrome, and whiplash-associated disorders. He received his Master's of Professional Studies with a concentration in biomechanical trauma from Lynn University. His doctorate in physical therapy is from the University of St. Augustine for Health Sciences. And he is a diplomate of the American Academy of Pain Management and a member of several medical and physical therapy professional organizations. So it's our great pleasure to have Jan here to speak with us tonight. And we're going to go ahead and load his slides for his presentation on the screen. And I'm going to turn the microphone over to you, Jan. Thank you so much for joining us and educating us about PT tonight.
Well, thank you very much, Deanne and John, for the invitation. And I've done this once before, so this technically is part 2. And it's really nice to see, I think, that based on your own experiences, that you're willing to set this up for people who were not as fortunate in eventually getting a diagnosis and getting the help they need. As recent as today, I saw a new patient from the Midwest who for many, many years was wondering what was wrong with him and just finally got a diagnosis, but then the problem came that where he lives, he couldn't find anyone knowledgeable about EDS and is trying to figure things out, but it's really quite frustrating, and I think that's more often the story of people than not. So I think it's a great opportunity. I'm happy to share some thoughts with everyone tonight about EDS and physical therapy, but I want to make it a little different than the first part of this series. And so I'm not actually going to talk an awful lot about physical therapy. It will come up at some point, but I would like to take the opportunity to talk a little bit about issues about why does it hurt all the time. Like so many people with EDS complain of pain. They're often dismissed by their doctors. When we ask pediatricians, well, how often do you see patients with EDS? I typically get the answer, oh, maybe every 2 or 3 years. And I'm quite sure that they probably see these patients every day, but they dismiss them with diagnoses such as growing pains or things of that nature. So it's frustrating, I think, for a lot of patients and a lot of parents of young patients and older patients who deal with EDS. And I must say it's kind of frustrating for me as a provider as well, that EDS is still not really taught all that well in our medical educations, or if in my case, physical therapy education. 30 years ago, or over 30 years ago, when I studied physical therapy, I do not believe EDS was ever mentioned, but that's not that different today at many schools of physical therapy. In my education company, in seminars, I often mention EDS, and more often than not, people's like, ED what? Who are you talking about? They're thinking about the other EDS, which is not what we're talking about tonight. So it is still an enigma for many people, and I think that's such a shame because there's so many opportunities to create a much better quality of life for people who suffer from EDS in whatever form or shape that may be. Of course, there are many, many varieties. I'm going to start with a slide I showed in the last presentation as well. So this is the exact same slide. That a study showed that 98% of patients with hypermobile type EDS have musculoskeletal pain. And so that's practically everyone. One study showed that 0.06% did not have pain, but the vast majority of people hurt all the time, in addition to lots of other problems, gastrointestinal problem, allergies, influenza-like things, the flu-like things. And if you look at another study in 2013, and this is also a slide I showed before, just to put it back into perspective, the most common area that people with hypermobility type EDS complain of is joint pain. And of course there are lots of other issues, but joint pain was by far the number one complaint. And that's quite amazing because if you look at joints of EDS patients, they look usually totally normal. There's very little wear and tear on the joints. So surgeons will tell you that, well, I did an arthroscopy on your joint and actually the joint surfaces looked really, really nice, and yet a lot of people complain of pain. And the pain can be quite severe. You know, in a Dutch study in 2010, 92% of EDS patients reported having chronic pain, and 87% of that group were actually disabled. So that is an enormous amount of people, of course, and I had to put in a Dutch study, of course. If you recognize my accent, I am from the Netherlands. I was born and raised in the Netherlands, and 1986 I moved across the pond to the United States and have lived there ever since in the Washington, D.C. area. So the Dutch study I don't think is all that different from other studies from other countries. I think that the amount of suffering that some people with EDS go through, a lack of understanding by the medical, physical therapy, and other medical professions is astounding. And so I think it's time that we continue to advocate for people with EDS and try to do the best we can in educating also healthcare providers, but also patients themselves. If you're a patient, you should know what to look for when you're looking for a healthcare provider in wherever your community, wherever you may live in the world, if you listen to this tonight. If you just take a step back and look at chronic pain, or what I prefer to call it, persistent pain in general, EDS patients are part of a large group of people with pain. The annual estimated cost to the U.S. government is about $250 billion. Annual healthcare cost is over $600 billion. And chronic pain, in spite of all these expenses, is generally very poorly managed, with success rate ranging maybe from 20 to 25 to 30%, which means that the vast majority of people with chronic pain, including EDS pain, really don't get any difference whatsoever in their pain status, and that is unfortunate. Deanna, I see that several people could not forward their slides, or did not see the slide changing. So do we want me to wait for that, or shall we just continue?
No, you're okay. Your slides are working fine. I think it's isolated to their devices.
Okay, very good.
Thank you.
And we'll go on. So recent studies show that chronic pain conditions are the primary driver of healthcare, and they cost more than diabetes, cancer, and heart disease combined. Let that sink in for just a second. More than diabetes, cancer, and heart disease combined. And yet, our success rate of treating people with chronic pain conditions, EDS, a subgroup of that larger group, is at best 30%. So I think it's fair to say, as that little picture shows, the iceberg, that it's one of the most underestimated healthcare problems in the world today. In the United States, there are at least 120 million people, adults, suffering from chronic pain. It is the main reason people seek healthcare. I mean, at least half those visits are attributed to some type of chronic pain. So, if we take it a step back from EDS and actually look at the bigger picture, it is kind of amazing that not more money is poured into research, that it's hard to find a clinician who knows much about chronic pain, and maybe even more important, why are clinicians not jumping up and say, hey, I saw a patient in my clinic today, I have no idea what's going on, how can I do that? What can I learn about it? In fact, that's how I became interested in EDS. As I told you, that was not part of my physical therapy education and my postgraduate studies. Now, no one ever mentioned EDS as far as I remember, but I vividly remember our first patient that I actually became aware that something was terribly different. We saw a gentleman from the United Kingdom who came to our practice. We had a pain management practice at that time with a pain management specialist, a physician, and this man had been hospitalized twice in a psychiatric hospital in England because people thought that there was something terribly wrong with him psychiatrically. He kept complaining about pain in his neck and shoulders, and actually over his whole body. His neck and shoulders were the worst. And when the physician palpated him and we looked at him together, he had very tight muscles, and we thought, man, the man has a lot of myofascial pain. He had trigger points in his shoulder muscles. When the physician injected one of these trigger points in the shoulder muscle, the patient's arm literally dropped 3-4 centimeters, a little bit over an inch, out of the socket in his shoulder. I had never seen anything like that before, but he basically dislocated his shoulder right in front of us. And we were like, what the world just happened? Well, long story short, he actually had EDS. He used excessive muscle contractions to keep his body together. And when that control was released with that trigger point injection, the patients lost the control and the arm basically dropped out of the socket. So that's when we realized, like, this man was really far from crazy. He had a substantial medical problems that honestly at that point we do nothing about. So we could have just said, like, well, it's an anomaly, we'll never see it again, we move on. But unfortunately, I think that's what probably a lot of people do. I'm not really sure. We decided to get better educated. And living in the Washington, D.C. area, we are very fortunate that we have some of the world's specialists in this area. And we contacted Dr. Francomano. Claire Francomano is a geneticist in the Baltimore, D.C. area. And at that point, she was still close to us. Now she's in Baltimore. And we invited her to come to our clinic and educate us about what just happened and what should we know about this condition. And that is now about 20-some years ago. And since then, we have been able to diagnose and work with people with hypermobility and connective tissue disorders ever since. So that is means of introduction. So a lot of my patients tell me that they did go to pain clinics and it didn't really hurt, or didn't help all that much. A lot of our patients tell me they went to physical therapy and at the same time they got worse. On our Physio Fitness website, we have several video clips that show that several patients of us who tell the story, I used to go to my physical therapist, but all I did is get worse and worse. Well, this joke here, go to a pain relief clinic, wouldn't that make more sense? That's just a joke, of course. But the fact is that going to doctors, going to physical therapists, chiropractors, and other health professionals is not always the answer you need to look for, because you don't necessarily get the help that you want. So if we consider why would that be, and an interesting study that was published just 3 years ago, in 2014, this was a study of the knowledge of physical therapy professors in schools for physical therapy, how much they knew about current studies of pain. And a few years ago, the Institute of Medicine published a very large report on pain, which everyone really should read. You can download it for free. And also the International Association for the Study of Pain has guidelines for each medical profession, what that profession really should know about pain. So they also have them for physical therapy. Only 61% of the professors thought that their students received adequate education, but worse than that, less than 50% of those professors had ever heard of those guidelines. So if the professors of physical therapy don't know much about pain and are not on top of what are the latest findings, the latest guidelines on how to treat pain, how can we possibly expect that physical therapists in my profession, but that's true for other professions, so would know anything about it? So an older study from 1991 showed that only about 4% of orthopedic physical therapists admitted that they like working with people with chronic pain. Actually, that's not really what the study said. The study said that 96%, mind you, 96% would prefer not to see patients with chronic pain. Now, that sounds like an awful lot of people, but I think that's probably today still quite relevant. We see a lot of patients from other states, and it's not really realistic for them to be here in therapy and work with us because they're far away. They would have to stay in hotels, and that's not always all that easy. And when I try to get providers in their local communities, I get very strange answers from other therapists. I don't do neurology patients. It's like, well, that's perfect because these patients are not neurology patients. Or I've never heard of this. I can't see those patients. It is very difficult to find clinicians who are familiar with EDS or with chronic pain in general. There's another issue that's a little bit more philosophical, but I think it's worthy of exploring together tonight. This was published just about a year ago in the January issue of the Physical Therapy Journal. And this was about knowledge, and it was marketed as the knowledge, the ever-expanding shoreline. Of course, it is almost impossible to know everything there is to know about every possible disorder and disease and therapy process. That's almost impossible. And the more we know, the bigger, as Alan Jetty says, the bigger the knowledge island becomes. Most people, most clinicians, and then just in general, I think you're most comfortable at the center of that island of knowledge, where you know what you know. It's comfortable, you've always done it this way, and this is the way it is. If you didn't learn it in medical school, if you didn't learn it in physical therapy school, maybe it's not all that important because it's all that new stuff. The bigger the island gets, the longer the shorelines, the less likely we will know what's going on at the edges of current knowledge bases in science. But that's a significant problem in the medical professions. I mean, the National Library of Medicine, which is right here in my hometown of Bethesda, has over 20,000 medical journals in its files. And yeah, that is absolutely impossible to keep up with everything. So in that sense, it's kind of understandable that not everyone knows everything about everything, but chronic pain, with the numbers I just showed you, and EDS being part of that, is the number one reason people go to see us. So how come we don't focus on that more and try to get more to the shoreline of our knowledge base to understand what's going on? This is an interesting quote. Experts are those who know more and more about less and less until they everything about nothing. Sorry, I almost messed it up there. When I lecture, I always tell people I know an awful lot about very little, but everything else I don't know much about. So it is true that we all have to make choices in what we focus on in our professional lives. I know very little, for example, about sports braces. Like if you need a knee brace to do a certain sport, I would probably not be the best person to ask because my knowledge base on that is still in the center of the island, and I really have not kept up on what goes on. I am much more interested in pain, persistent pain, and dealing with like how can we deal with that. So there's definitely some truth to that. 68%, as you see here, 68% of physical therapists use interventions with strong or moderate evidence of its effectiveness. You would wonder, like, why is that not 100%? Well, the truth is that we don't always know what to do with patients. And that is very, very true. Many things have never been researched. Certain techniques that people may use, certain ideas that people may have are interesting, but the research base is lacking. There's very little really strong evidence for what happens in physical therapy, chiropractic, other professions as well. So this is a fairly recent study. 68% use strong, moderate evidence. And as Jetty said in that article again, physical therapy remains a pragmatic discipline even when there's uncertainty. Even if you don't have the latest research that's possibly available, maybe you don't have access to it, or the research is not done yet, but you're trying to expand your knowledge base, and EDS is a good example of that. If we get closer to the shoreline, I'd be walking there, what do we really know? In my first lecture a while back, I mentioned that the research on EDS is abysmal. There is very little good research on physical therapy and EDS, for example. So we still have to deal with then what are we going to do if our knowledge base is limited, either because we stay in the center of the island, or we actually trying to reach out to the edges, but not much has been published. What do we do when we do not know what the correct intervention is? I think it happens quite a lot, and we're not always willing to admit that. So this article really was quite interesting. I'll start a little cartoon for you about what to do. Here the doctor said to the patients, I'm not feeling great, give me the strongest painkillers you've got. Whoa, I'm a medical professional. I'm not going to hand out powerful narcotics without making sure they're right for you. So open wide and say, okay, yes, that is a perfect place to put all those pills. So sometimes we make decisions based on an impression we have, then the answer we give may not necessarily be the best possible answer. But I think fair to say that a lot of people, most clinicians probably, are trying to do the best they can do, but we don't always have the knowledge base to do it properly. 90% of physical therapists use interventions with limited evidence. And if you're a patient, listen to this, like, oh my gosh, I mean, how bad can it be? The fact is that the evidence is not always there. We don't always know. Now, this study was for acute low back pain. And you would think, like, well, everyone has low back pain once upon a life. How come we don't know much about that? Well, I can tell you other studies that are not in my presentation tonight. But about several years ago, there were 50 orthopedic surgeons were giving a scenario of a patient with low back pain. And they were asked, what is your primary diagnosis based on this case report? 50 surgeons had 47 different diagnoses. So I think it's a very common problem. If it was so clear cut that, okay, with these centers, this is the kind of back pain you have either a disc problem, or you have a muscle problem, or you have another spinal problem, whatever it may be, 90% of physical therapists used interventions with limited evidence. And that's a big problem, of course, because if you're a patient with EDS, how do you know you're going to get the best possible treatment? So Jenny says that now, how do we learn? We have theoretical databases. We can look at the theory, and I'm going to do that with you tonight a little bit. We may have past clinical experience. You know, this really worked on those 5 patients, and that's going to work for you as well. We can look at the prognosis, or we can look at scientific evidence. So we have more than just knowledge. Knowledge is a much broader concept. And the cartoon said, is it right to remain ignorant? I don't know, but I refuse to find out. That's not the physical therapy you want. You want someone who's willing to look, okay, what are those edges of the shoreline? Where can I find the best possible information? So if we don't know the science, if we don't really have the best possible research, and in EDS, unfortunately, that is more often the case than not, I think you should always demand from your clinician, whether it's a physical therapist or anything else, that they don't act on false pretexts. They don't tell you stuff that's not based on anything, and like they pretend to be knowledgeable, and in fact they really don't know. Yeah, as Jaddy says, ignorance of causal effects and ambiguity are the order of the day, and I think it's perfectly okay to acknowledge that, to say, like, you know, we don't have all the answers, but if we go back to the previous slide, we do have a theoretical base, we do have a clinical experience, we have seen other people with your condition, and there is limited scientific evidence. Based on those things, yes, we can expand our shoreline, we can expand what we know and what we don't know. Let's give this the best possible option. Let's start there. So the numbers get worse. 96%, that's almost everyone, of physical therapy used interventions with absence of evidence of effectiveness. So we do a lot of things that are not necessarily scientifically proven. But that's true in every field of medicine. A lot of things are experimental, a lot of things we don't really know. So against that background, I want to point out something else. Now you're looking at this slide, so what the heck is this? This says vomit, for those of you who have audio only. Why do I have a slide of vomit? Well, vomit has become an acronym. It's a short for a much more important thing called Victims of Medical Imaging Technology. And I think that happens a lot, that we can get MRIs of patients, we can get a CT scan or even an ultrasound or an X-ray of any of that, and people many times draw major conclusions from those studies. Let's take an example of low back pain. I recently had a young patient in her late 20s, and she was in a taxi and got rear-ended. So she got tumbled around in the car a little bit and had a lot of pain. She was suffering a lot. She had a lot of pain. So one of her doctors, when she didn't get better, ordered an MRI. So she was 28, 29 years old, and the report said that she had degenerative disc disease at almost all her neck vertebrae. And when she came to see me, she was so devastated. She said, you know, my life pretty much has ended. I have the spine of an old lady. That's what she was told by her doctor. Now, that's probably not the smartest thing because it doesn't mean anything. If you look at studies of other people who don't have any symptoms, you'll be amazed how many people in their 20s have degenerative disc disease. It's like saying, you know, if you could see me, and you saw my picture in the introduction, my hair is pretty white. My hair wasn't always as white, and as Kieran O'Sullivan, he's a physiotherapist in Ireland, in one of his lectures, he had a great analogy. He said, you know, I don't have degenerative hair syndrome. Yes, my hair does not look the same as it did 30 years ago, but that's just the normal process of aging. You get older, there will be certain changes in our body that before the arrival of the MRI and the CT scan, we couldn't really tell. And no one would make that diagnosis of degenerative disc disease because you couldn't see it. Because we can see it now, you have back pain, you get that MRI back, and it's like, oh my gosh, you have a bulging disc, or you have a prolapse, or you have whatever it may be. And then the conclusion is that is why you have pain. Well, many patients who are dependent on a film like that suffer from the vomit syndrome. They are become victims of medical imaging technology. So let me show you an example of that. Patients with rotator cuff pain, you know, the shoulder pain, a lot of people have that. It's best known for baseball pitchers, of course. Almost 400 patients, if you look at the bottom of the slide right here, almost 400 patients, I don't know if you can see that, of the patients had problems, but the conclusion was the anatomical findings had nothing to do with the level of the pain that they experienced. So yes, you could look at the picture. They had rotator cuff tears. There was no correlation between the size of the tear and the level of pain these people experienced. So another study with a great title, it's 11 years old now, but the title doesn't change. Dead Men and Radiologists Don't Lie. What a wonderful title for a paper. They looked at cadaver studies, so people who had passed away, and radiological studies, X-rays of MRI, ultrasound in this case. And they found, if you look at the table all the way on the right, that the asymptomatic ultrasound and symptomatic were basically the same number. There was no difference. They were not statistically different in people with symptoms and people without symptoms. Their shoulders looked exactly the same. So you can't really say, based on that image, the ultrasound or even of the MRI, oh my gosh, that is the problem. In EDS, we see the same thing. People get imaging studies done that don't always have a lot of significance for the problem. Of course, there are exceptions. There are lots of studies. A lot of people with EDS have other complicating factors like Chiari malformations. Those are a little bit different. Those you have to look at because those could have significant problems. But as far as back pain, in this study here from Japan, over 1,200 people in the 20s, just like my patients who got rear-ended, over 1,200 people, asymptomatic. They had no problems whatsoever. 3/4, 75% about males and females had bulging disc. As you see in the picture on the right, had bulging disc. So you can say, ooh, I see you have some neck pain or pain in your shoulder. Ooh, that's because you have a bulging disc that causes the problem. Now you need surgery. If 75%, 73, 78% to be precise, of asymptomatic subjects in the 20s have bulging disc without any pain, how in the world can you conclude that that is the problem? Same here. This is a study from 2014, compared 20-year-olds and 80-year-olds. Asymptomatic individuals, so no pain whatsoever. These are healthy individuals, nothing wrong with them. 37% of the 20-year-olds and 96% of the 80-year-olds have disc degeneration. So if more than a third of 20-year-olds have it, is that really a problem? Is that just something that happens to our spine, just like my hair changed color over the years and, okay, now I have degenerative hair disease? The same study also looked at disc bulges between those same groups, 20-year-olds and 80-year-olds without any symptoms. 30% and 84% had disc bulges. Yeah? Disc protrusion, that's even a little bit worse. Those numbers for the 20-year-olds were very similar, 29%. The 80-year-olds had a little bit less of that, 43%. But these people have no symptoms, so you can't rely on medical technology all the time. Yes, it has its place, of course, but many times people get overdiagnosed for problems that don't really exist. So you have to be very careful with that. A lot of this thinking of MRIs is based on what I call somatic lesion thinking, where people want to find something that is broken so we can fix it, preferably with surgery or with an injection. But that all has a very strong biomechanical basis. So I think it's time that if you look at where to go for healthcare, if you're a healthcare provider, let's get out of our biomechanical box and look at some other things. So here you see a picture from the desert in the United Arab Emirates. So my objective tonight is to introduce you a little bit more of the neurophysiology associated with what's called nociception and pain. So I'll explain what that's all about. So if we ask the question, what is pain? The first thing you have to understand that there is no such thing as a simple answer. There is no simple answer for that question. If you make it too simple, you clearly don't understand how incredibly complex pain really is. It is the number one reason people come to the doctor, and it is not a single straightforward answer. Simple construct models of pain have limited usefulness. They really don't work. They can't guide our clinical interventions. Very influential neuroscientist and physiotherapist from Australia, Lorimer Moseley, said many years ago, 2003, that pain is produced by the brain. So listen to that. Pain is produced by the brain when it perceives that danger to body tissues exists and that action is required. If we let that sink in a little bit, pain is in the brain. That is the philosophy, which also means that in the people who follow this thought, you just need to fix the brain and how the brain perceives things and how the brain acts, what the brain does, how the brain perceives danger. So there is a fairly large group of physiotherapists who think that focusing on the brain is really all you need to do. That there's no room for hands-on techniques anymore because the issues are not in the tissues, as you'll see in a little bit. The issues in the brain is misinterpreting information. It perceives that danger exists and something needs to happen. Well, there's a lot of truth to that. So in other words, pain would be an output system rather than an input system. Yeah, the pain is the result of something else. It's an output system that, in fact, the brain would produce. So the notion of pain is in the brain is very important, because I think there's a lot of truth to that. But as you'll see as I talk a little bit more about it, I don't think it is the whole picture. And even with EDS patients, if you ask my patients, where is your pain? No one has ever told me the pain is in my brain. No, the pain is in my shoulders. The pain is in my back. The pain is in my hips. I keep dislocating my ankles. I sprain my knees all the time. No one has ever told me pain is in the brain. So it's a bit of a hard concept to understand that pain would be in the brain. And some people interpret that, especially patients, will often say, what do you mean it's in between my ears? You don't believe that I have real pain? So the term is a bit ambiguous, I think. I understand where people are coming from when they say that pain is produced by the brain. No brain, no pain is the equivalent of that statement. You do need a brain to have pain. There's no question about that. But the term pain is in the brain, to me, is a little bit too simplistic. But it is very important. So if you follow that idea that pain is in the brain, you need to look at what's called top-down regulatory mechanisms. So I'm going to see if I can turn my cursor back on. I don't think it worked before. So if pain comes in, if you look at the picture on the right, at the bottom right it says pain signals, and these pain signals are going into the spinal cord, into the dorsal horn in your back. That signal is strong enough, intensity and frequency, and or repetitive enough that at some point that signal reaches a threshold, it goes up in the brain, and it reaches parts of the brain like the thalamus and another area called perioccipital gray. And the brain thinking, the brain makes an assessment. Is there danger? And if there's no danger per se, the brain activates what's called the descending inhibitory system and tells the dorsal horn, the spinal cord, basically, I don't need that information. You can keep that. Stop sending me to you. That is a normal process that happens every day in people without chronic pain. So normal is that signals come in. If the signals are fairly weak, you don't even notice them. If they get stronger or more repetitive, it will go up into the brain and you have an experience of pain. That's normal. So the brain regulates the perception of pain. It can block these signals quite well and deal with that. It's actually a little bit incorrect. When it says on this picture pain signals, you see it on the right-hand side in the slide. Pain signals, you see it also in the part that goes up into the brain. That really is incorrect. What it should say is actually nociception. So when we look at that, pain signals is incorrect, and really what it should read is nociceptive input. So that's a fancy term that just means it's not pain yet. It is just information from the periphery, from the muscles, from the joints, from other part, the skin, of course, is a big part of that. All these systems have sensors. They have what's called receptors that register when something is about to go wrong. And if that system is just a little bit, not a big deal, you won't even feel it. It's got to move on. But if you are chopping onions and you happen to slice part of your finger, that nociceptive information is so strong that it reaches the threshold right here in the dorsal horn, and indeed that nociceptive input goes up in the brain, and that's where it becomes actual pain. So pain and nociception are not the same. They are two different creatures. So here you see, I will not equate nociception with pain. We all have nociception all day on. We have information coming in all day on into our spinal cord, but most of these signals are not really strong enough to make it up into the brain, where we then say, ooh, that really hurts. So, on the normal circumstance, let's say you have EDS and you dislocate your shoulder. Now, this guy is a little bit too muscular for that. Most EDS patients don't quite have this many muscles, but let's assume you have pain in your shoulder. On the normal circumstances, that pain signal goes up in the spinal cord, it goes into the brain, the brain does an assessment if you want, it comes back, and there's an action back to the shoulder that basically says, okay, you need to slow down a little bit, or don't lift your arm quite as much, or don't pick up that many weights because it causes a problem. In many of chronic pain patients, that same injury to the shoulder leads to a much bigger response in the brain. If you look at the two regions in the brain, these two brains right next to each other, you see on the normal circumstance it may just involve a small part of the brain, and on the picture on the right, on the sensitization, when the nervous system is responding much stronger than you would normally think, it takes up a much bigger area in the brain, and instead of having a response like, well, don't do this, it is just pain. And people experience pain all the time, and it gets very annoying because now you have what's called central, or sometimes what's called peripheral central sensitization. What that means is really that your brain, your nervous system, is working way too well. It is too efficient. It picks up signals it should not respond to. So in extreme examples, we don't see that much in EDS, but in some other pain syndromes, people can't even put on a shirt without having pain. Yeah, that the weight of the shirt on the shoulders actually hurts. The air of a moving ventilator or an air conditioner can actually hurt. But EDS patients definitely many times have sensitization. Your nervous system works way too efficiently, and a big part of it is indeed treating the nervous system and slowing down. Chill the nervous system. The brain needs to chill a little bit more. So that's what we need to really understand. That hypersensitivity, that functioning of being way too efficient happens in all levels of the nervous system. Not just in the brain, it happens in the periphery, peripheral sensory neurons. They call it happens in the spinal cord, where we're talking about spinal neurons. These regulatory systems from the brain back to the spinal cord, those top-down modular systems are problematic. And it even involves abnormal immune cell functions. There are many immune cells in the nervous system as well. Actually, the brain has more immune cells than neurons, and those also get involved. So the whole nervous system becomes too reactive, becomes too efficient. And that is a big part in most of EDS patients, where the nervous system just functions way too well. That is referred to as central sensitization, particularly. So how does that work? Well, we have what's called nociceptors. Nociceptors are basically registration systems that can pick up a lot of impending dangers to us. Certain chemicals that may be in your body, or a hot temperature. If you put your hand near a hot stove, you better pull your hand back, because we have sensors that respond to that high temperature. And those sensors, those are called nociceptors, because it could potentially become painful. Those receptors, those nociceptors, tell your body, ooh, that is potentially dangerous, that's way too hot to put your hand on. You better pull your hand back very quickly. Yeah, so if you look at, there's many different definitions of nociceptors, but here's one that says it's a nerve ending, a sensory ending that detects actual or potential tissue damage. Another thing is that it's an ending, a nerve ending, that can figure out if a stimulus or a discharge behavior that is a stimulus is either something you can forget about, an innocuous stimulus, or is it a noxious stimulus, a nociceptive input that requires action. So all structures have these. That picture on the right side of your screen looks at lots of those receptors, and we have them for lots of chemicals. We have chemical receptors for pretty much every chemical. Serotonin receptors, prostaglandin receptors, we have bradykinin receptors. These are all chemicals that play functional roles in our body, except when we get too much of them or too little of them, or when these receptors are open all the time, they change function. Each one of those receptors has a particular function, and typically in chronic pain conditions, they all do the wrong thing and make the pain worse and worse. I could lecture just about one of these receptors. You see it on your far right-hand side. Glutamate receptors. I did a lecture last year at the Physical Therapy Convention and talked for about 2.5 hours just about the role of glutamate receptors. So it's very complex. So all these things, once they get activated and it reaches a certain threshold, each one of those receptors can contribute to a pain experience. So there are lots of potential input systems that make us hurt more, that make us feel more pain. And that's a problem. And where are these things? Well, these nerve endings are everywhere. They're in the skin. They're in your internal organs. They're in muscles and tendons. They're in joints and ligaments. And then we have even a third one, and a fifth category, those so-called silent nociceptors. They don't really get activated till they get really annoyed when there's a lot of input, and then all of a sudden they take over as well. Those tend to be in the spinal cord. So these receptors, these nociceptors, are linked to all these different tissues. However, that's not really where they're based. We have free nerve endings in these tissues, but the receptors are actually based in another structure that we'll point out in just a second. So the function of these nociceptors is to alert the body for danger. And pretty much all organs have them, except a few areas that don't have those receptors, those nociceptive endings. like the brain, certain parts of the lungs, liver, and cartilage. We have no receptors in cartilage, which means that you really can never ever have any pain experience in these tissues. Yeah, we don't have liver pain. You can have severe liver disease and not have any pain in your liver because there are no sensing organs, sensors or receptors or nociceptors that would be able to tell you, to alert you like, hey, there's a problem in your liver or in your cartilage, for example. A lot of people don't realize that they're about to have pain from arthritis because the cartilage may be wearing down, but that is really not something that hurts because we do not have receptors. We do not have nociceptors in cartilage. So the stimulation threshold, so when do these things become activated? It's right before something would go wrong, right before the tissue would get damaged. So the function of these nociceptors really is not to tell the brain that there is already tissue damage. They're designed to tell the central nervous system that something is about to get bad unless you do something. Yeah, if your hand comes close to that hot plate, you already know, like, oh, that's really hot, I better pull back. If you don't have these sensors, you just put your hand on the hot plate and not even realize you're burning yourself. Yeah? That would be a big problem. So in a way, there are people who do not have these nociceptors, who don't have this registration system that alerts them that something really bad is going to happen to whatever part of your body you're dealing with. Whether it's your hand on the hot plate, or if you walk barefoot, if you step on a piece of glass and you don't feel that you just cut yourself, you could have significant infections and not even know you did that. The people who don't have these nociceptors have very difficult lives, and many times they don't really live very long because their body is just falling apart. Certain diseases have it, like diabetes. You can have what's called peripheral neuropathy, and in peripheral neuropathy, these sensors stop working as well as they did before, so people with diabetes should really check their feet every day. They walked barefoot or on their socks or whatever, certainly outdoors, on the beach maybe. They should always check, did I cut myself today? Because they may not be able to feel that. So in a way, when you have pain with EDS, you know for sure that your receptors, your nociceptors, are working perfectly fine. The problem is that the brain is too accessible to that information, to that nociceptive information. It comes in, it should be blocked at the spinal cord, it should not go further into the brain, but in many cases of persistent or chronic pain, everything goes through because the threshold is being lowered and lowered and lowered, and at some point, anything you do hurts. You try to move your arm, you try to pick up something, you try to pick up a bag. Besides the subluxations and the dislocations that many people with EDS suffer from, just the pain system has changed its thresholds, and the brain interprets anything that for other people wouldn't be painful at all as painful. And of course, that's very difficult to understand for your friends and family members, because if you have this sensitization issue, you still look totally normal. The patient I saw today, I told him I was doing this webinar, he listened to the previous one, he told me, he looked perfectly fine. There was nothing wrong with him, unless you start looking a little bit closer. You can say, you do move your shoulder blade an awful lot more than most other people. And say, yeah, and it hurts all the time. Yeah, that is what sensitization is all about. It looks fine, it looks normal, but the brain is too reactive, and the brain picks up information that it should just leave alone. So, this is a famous researcher, Mr. Basbaum. He is a researcher in California, I believe, at the University of California. He says pain is not just a stimulus that is transmitted over specific pathways. It is a very complex perception. Yeah, listen to that. Pain is a complex perception. Information comes in, and we all have our own way of dealing with that. But when it becomes chronic pain, it gets much more complicated than just a little cut or something else you may do. Well, Dr. Basbaum also said the nature of that perception depends not only on the stimulus, on the intensity of the stimulus, but also in the situation in which it is experienced. So it depends a little bit on what's going on. And we all know, we've all heard stories of people in war times who get terribly injured from explosive devices. They may be missing body parts, but they keep running. They keep running away from the scene of danger. And when they're back in safety in their own barricades, in their own jeep or tank or whatever they may be in, they look at that arm and then all of a sudden they have pain. Before that, these soldiers, many examples, did not report pain. Why is that? That was because their brain was preoccupied with other things. Their brain was preoccupied with, you need to get out of here. You need to literally run for your life. So the motor cortex, the part that controls our movement patterns, in those soldiers took over everything else. And the part that deals with pain, the parts of the brain that deal with pain, they were temporarily turned off because the situation in which they experienced it demanded that they focus more on run for your life than says, oh, that really was painful. I'm going to sit down here for a second and watch my arm because I'm really not happy about how that feels. Well, if you would do that, you wouldn't survive, per se. So we talk a little bit more about pain and the perception. Here you see a beautiful park. It's actually on the water. You see an ocean behind it. This was the view from one of my hotels I stayed in last year. I have the big privilege of traveling all over the world. I teach a lot of lectures and I teach a lot of courses to healthcare providers, in addition to being a practicing physical therapist, of course. But if you take a look at this picture, what do we see? What do I see? I see a beautiful ridge. There's some mountains there, some palm trees, very beautifully manicured grass. This was in Oman, actually. But if my dog looks at the exact same picture, that's not what my dog focuses on. My dog sees a place to go to the bathroom. Yeah? Very different perception. Same scene. We both looked out of the balcony, look at this beautiful park. I see nothing but beauty. Say, oh, I really want to go behind these trees and take a look at what the ocean looks like there. My dog says, oh, I love those trees. I can pee everywhere. This is like doggy heaven for me. Very same view, different perception. I'm not saying that doctors look at you as a place that you should pee, but pain is a perception. If you look at this picture, we show this in our courses, actually, the same picture. You see a voluptuous nude in the back, and you see a little girl in the front trying to draw this model. And there's 3, 4, 5 efforts, and none of them, in my opinion, really look like the model. But is that really important? It is her perception of what she feels and what she sees and what her sensory skills, her input is. Pain is just like that. Pain, by definition, is a perception. If you look at the website, painexhibit.org, I highly recommend that. I look at that quite often. These are artistic works of patients with persistent pain. Yeah, one patient here showed his or her hand as flaming, as burning all the time. Maybe that person has neuropathy. You see a couple of feet with pieces of glass in the bottom. You know, that's how you walk if you have pain in your feet every single day. Or the picture in the middle, you know, how striking are these pictures? The website has a lot of opportunities to upload pictures as well and really share with other people, like, this is what pain really feels like. And some of the artworks are quite amazing. So pain is whatever the person who experienced the pain, whatever that person says it is. It exists whenever he or she says it does. There is no point in arguing about pain. By definition, pain is always a perception. That doesn't mean it's in between your ears. That means that we can't argue about pain. Pain is whatever it is. If my patients tell me, I have pain in my shoulders when I do this, I have pain in my knees, I have pain in my hips, when I walk, my whole body hurts. There's no reason for me to question that. Why would I question that? It's your perception. That doesn't mean it's not real. I get that question sometimes from insurance companies, from adjusters. They tell me, well, doctor, do you think so-and-so's pain is real? And I'm like, how am I supposed to answer that question? What do you think? It's not real? I'm sure they want to find out if you're malingering or not. Well, that is extremely rare. Yeah, extremely, extremely, extremely rare. So if we continue this, the problem with pain, with chronic pain, and this is from their colleague of mine, Adrian Law. He's also an educator, and he has a continuing education company as well, but he's written a book chapter in one of the books I've edited. So you see at the bottom, Manual Therapy of Musculoskeletal Pain Syndromes. And he said it so perfectly fine, so I give him credit for doing this. He said in chronic pain, many parts of the brain are literally enslaved by pain. Just like the soldiers, when they had to run away and part of their arm was blown off, they didn't think about the pain, they just thought about running away. Their brain was fully occupied with, you better get out of here. Yeah? But in chronic pain, your brain may literally be enslaved by pain. That's all the brain has time for to fuss about. Anything else you want to do is going to be a task. Yeah, exercise or specific movements. You may work with a therapist, well, you need to work out. And he's like, well, I'm trying, but it doesn't work, it hurts. Yeah, if you have that response, maybe the whole brain, the part that normally deals with movement, with walking, with running, with thinking, even with cognitive things that maybe you forget everything. In fibromyalgia, people call it fibrofog, but I think it's typically for many chronic pain patients that you just are not totally on your game, that you don't always remember things, that you forget things, you forget appointments, you forget to set your alarm clock, and then of course you don't wake up, or because you're up half the night, whatever it is. So once in chronic pain, once the brain is so preoccupied with all that incoming nociceptive information, turning it into pain experience, any kind of other activity, whether it's thinking or movement or exercise, it can be very, very, very difficult. So in a way, it is correct that we, even in EDS patients, in physical therapy and other disciplines, we need to understand that the brain plays a critical role in why you have pain all the time, why 99% of hypermobile EDS patients complain about joint pain. So here you see another example, also from Adrian Law, in the same book chapter. The reference is at the bottom of your slide. It cut off a little bit, but that's okay. This is an MRI of a patient brain in rest. So this patient is just lying down, and when the patient was asked to do a simple pelvic tilt, which is not a big deal for most people, but this is a chronic pain patient, if you look at the whole brain is lit up. So in that MRI, a lot of parts of the brain are lit up. Now, this is not my patient. This is reported in this book chapter, so I copied and pasted it into this slide. But what you can see during a simple pain experience, not a big deal, we're not lifting tons of weight, just at a little pelvic tilt, multiple areas of the brain are activated at exactly the same time. That brain is preoccupied with pain. It's almost like the brain can't think about anything but pain. Probably the movement, the quality of the movement of that moving your back and pelvis a little bit is probably rather poor. Sometimes people don't even remember how to do it. It's like, oh, I don't know how to do that, because their brain is so busy dealing with all these nociceptive input signals and dealing with pain that nothing happens. It used to be said that pain is in this part of your brain or that part of the brain, but pictures like this really show that in chronic pain conditions or persistent pain, like with EDS, multiple parts of the brain are involved. You see them listed at the bottom of the slide. Anterior cingulate area, the primary sensory cortex, the thalamus, I already mentioned that. Anterior insular prefrontal, posterior parietal cortices. A lot of parts of the brain get busy focusing on pain and nothing else, doing a simple motor task. If your physical therapy gives you a lot of exercises without much guidance, so it's like, okay, you need to lift weights, but every time you do, you pop your shoulder. Well, just imagine what your brain would look like at that moment. That brain is firing all over the place, telling you, have you lost your mind? You need to stop doing this, because I can't handle it. It is too dangerous. It's pending danger. The whole brain is lit up. There's no reason why you should do this exercise. So there's another aspect to that. It's called long-term potentiation. What that really means, that the first time you do that exercise, in the picture on the top, okay, you get a little response. You're like, oh, that didn't feel good. But now the therapist says, okay, let's do 15 repetitions, 3 sets of 15. And you keep stimulating that. Now you get a much stronger response if you do that. And after a while, you just need to do one single thing to get that same strong response again. So the body gets more sensitized. The nervous system has learned to respond to a single stimulus as if it's like a whole lot of stuff going on at the same time. That is called long-term potentiation. In a way, that's actually the way we learn. When babies, little children learn a new task, they do it once, it didn't work so well, they try, like learning how to walk. How many times do babies fall on their diaper? They keep trying, and parents often want to stimulate their kids. I always wonder, like, let them just crawl. It's much easier for you as a parent. You don't want them to walk so early. But parents typically, and I'm sure I was guilty of that too with my children, parents typically said, oh, let's walk, and can you walk to daddy, can you walk to mommy, can you walk to grandma? Giving that kid enough stimulation to learn, and long-term potentiation is learning with less information to do the task to have a bigger output. It's actually the physiological reason for learning in general. But when it becomes to chronic pain, it's a problem, because every time you move your joints, if you were a soccer player in your high school years or middle school years or whatever, junior high school, whatever you call it, and every time you sprained your ankle, you got set yourself up for more long-term potentiation. Your brain, your nervous system learned that that activity really is not a good activity. And at some point, you really don't have to do the whole activity. You don't have to play a whole game of soccer to have the same outcome, to have the same response. And that usually is pain. So at a physiological level, the picture at the bottom, lots of things happen. Here you see some of those receptors that I mentioned before, these nociceptors, in this case for glutamate. And when that happens, even at the most basic functions in the central nervous system, everything is changing. So there are actually physiological changes in the body, and we don't have time to go over that tonight, but there are a lot of physiological changes that facilitate that whole process of having much stronger responses to the same, maybe non-painful stimulus, but now you experience that as painful. Lifting up your arm should not be painful. Walking across the street should not be painful. But if you have long-term potentiation, your brain will interpret it as painful because that's what it has learned to do. So traditionally, physical therapists either have followed what's called a bottom-up approach, so manual therapy and trigger-point therapy and joint mobilizations and exercise even. When this notion that pain is in the brain became more popular, some therapists said, no, you should never do this hands-on stuff because pain is in the brain. You need to do what's called top-down therapies. Yeah? Focus on the brain. Relax people. Tell people everything will be okay. That's the way you should do it. Well, I'd like to focus on that. This book that I mentioned to you before, so this is almost like an advertisement. It's not meant to be. Manual Therapy for Musculoskeletal Pain Centers. We actually asked most of the authors, can you focus on that? Can you include these things? So the chapter by Adrian Law I mentioned does that very nicely. They said, okay, when you explain pain, kind of what I do with you tonight, when you explain how it works, it's usually called therapeutic neuroscience education. Some people call it pain neuroscience education. Combine it with manual therapy and exercise, that works a lot better. So we need to train the brain, but we can also do that in combination with other things. So sometimes pain is called, sometimes my patients, I've been told that pain is psychosocial. Yeah? And that also steers people away from doing hands-on therapies. So if you have a patient with osteoarthritis in their knee, you can say, oh, pain is in the brain, but you can't really ignore that there is still a problem in the knee, or in the low back, or in EDS in the connective tissues. there are still issues going on. So if you look at the picture on the right, you see there's information from the knee in picture A. That's a symbolic picture of the knee. There's information in the red line. You see the nociceptor written in the corner. It goes through into the nervous system to a structure that's called DRG. You see it on the screen, DRG. That means dorsal root ganglion. All the input systems go through that dorsal root ganglion before it actually goes into the spinal cord, into the dorsal horn. And once it's strong enough, it actually goes up in the brain. So you can say, well, we could just do top down and not worry about the knee, but why wouldn't you do something about the knee and see if you can change that, what's called peripheral nociceptive input? Even in cases like fibromyalgia, which a lot of my EDS patients get diagnosed with as well, fibromyalgia pain is dependent on peripheral input. It's still the input from the muscles, from the joints, from the skin, cutaneous inflammation, all these receptors that we have in all these structures is still very important. And you can actually change the overall pain experience from patient fibromyalgia and from EDS by removing that peripheral nociceptive input. And there's lots of different ways for that. You see two terms on the screen here, allodynia and hyperalgesia. Allodynia is a painful experience following a non-painful stimulus. So if someone touches you lightly, that shouldn't hurt. But if light touch, for example, hurts, or simple movement, if it hurts, that would be considered allodynia. Hyperalgesia is a stronger painful response to something that normally is a little bit uncomfortable, but now it's totally out of proportion. So here you see a schematic of a nerve, and you see in that nerve you see different fibers, A beta fibers, A delta fibers, C fibers, and also a sympathetic fiber. And they go through, here you see that again, dorsal root ganglion before it goes in the spine. Well, that dorsal root ganglion is important because that dorsal root ganglion, as you see it here, right here again, I clicked on it one more time, there's your dorsal root ganglion. We all have it. And every input from the periphery, whether it's some light touch with a feather or a hand, or you hit yourself with a hammer or cut yourself with a knife, or you have extreme heat, like the hot plate, or some chemical, maybe hot peppers, all these signals go through that dorsal root ganglion, and that's where our nociceptors are. That's where the registration system actually is. We have nerve endings on one end, nociceptors in that dorsal root ganglion, and they actually play an important role in our pain experience. Here you see a video of a couple of videos. This is actually technically a video. It doesn't work well we had to change the slides to PDF so they don't work as well. You see here a little bit movement. That is nociceptive information in the dorsal root ganglion. If I hit it again, look at the picture on your right. You see a little bit movement there. This dorsal root ganglion actually releases chemicals in response to that input from the periphery, from that nociceptive input. And these chemicals go back to the right into the periphery, into your joints, into your muscles, but it also goes on the left, it goes into the dorsal horn itself, and it causes problems there. So on the one hand, on the picture on the right where it says periphery, you actually get sensitization in the periphery, so your arms may hurt more, your legs may hurt more, your body may hurt more, but you could also get sensitization in the dorsal horn. That by definition is your central nervous system, so that can also get more sensitized. So unfortunately we couldn't get these videos to work in this presentation, so the conclusion that some people said that the issues, quote, are not in the tissues. Well, that is true and that's not true. Because I think when we say there is no such thing as muscle pain, or joint pain, or bone pain, because pain is a perception in the brain and it doesn't matter what connective tissue it comes from, yeah, there's truth to that, but it's also a little bit too simplistic, I believe. And even that same Lorimer Moseley, who I told you before, who came up with that term that pain is in the brain, 2 years ago, actually 3 years ago now, he said, you know what? I've given this a lot of thought, and I really thought it was a property of the nervous system. I've come to realize it's not just the nervous system. It's of the whole body itself. It's of the human. You can still override your pain. You can decide to go out anyway in spite of having pain. It's not that your brain says, oh, don't do it and therefore you can't. No, you are the human being who can determine, okay, it's pain. Is it worth it? Yeah, it's probably worth it. Okay, why would I not do this particular activity? I ask my patients, how often do you have pain? And many say 24/7. Like, well, and it's the pain doesn't matter what you do. No, the pain is always bad. And the question is, why are you staying at home? If the pain is the same, why are you not going out and take a decision that you can move on? We have to understand that every pain problem, acute problem, has a thinking, reasoning, and emotional brain attached to it. That's a beautiful quote from the late Louis Gifford, who was a physiotherapist in the UK who studied pain in great detail. It's always more complicated than we want to acknowledge. So, as Adrian Law mentioned in this chapter, and then we try to do in our physical therapy clinic, when we see patients with EDS for pain management, which is what we do a lot, of course, it's really not an either-or. We do bottom-up approaches and we do top-down approaches. We explain what pain is all about, how the nervous system is too efficient, but we also say, well, you still have contributing factors from the periphery, from your muscles, from your skin, from your joints, etc., that may be contributing to your pain. So we really, to do a good job, we should address both of them. So bottom up, you see here a patient with back pain, and a funny little picture, I think. I found this online. I did not make this myself. If you can reduce or eliminate the nociceptive input from joints, muscles, tendons, skin, fascia, internal organs, or viscera, maybe you want to do trigger point inactivations, dry needling. Maybe you want to do joint mobilizations, or massage or exercise. Now, all of these things are great, and they also have significant problems. I teach a lot of dry needling courses, but dry needling is not always just okay for some patients with EDS. I do believe that patients with EDS, as I explained in my first lecture a while back, that a lot of people with EDS create taut bands, create contractions in the muscles, just like my patient from England many years ago. And when we needle these tissues, all of a sudden they relax so much that we create more hypermobility and more problems. Same with joint mobilizations. I'm convinced that most people with EDS do not need joint mobilizations. If your spine is a little bit stiffer on one part than the other, be happy, celebrate that at least part of your spine is doing its job, and the hypermobile parts are the problem. So we have to be careful with what we do. Same with exercise. What kind of exercise do we do? We should always do these things with the goal of reducing nociceptive input and really take care how we do that. The nice thing is that more recent research, and you see this is from not quite saying last year because we're now in 2017, of course. So techniques, these hands-on technique can also activate that dysfunctional descending modulatory system from the brain back to the dorsal horn that I explained to you before. So we always, as the title of these articles says by my colleague Enrique Ljurkin, he's in Spanish, but he currently studies in Belgium. We presented at a conference together not too long ago in Belgium, and his research clearly shows that if you balance these two things, hands-on and hands-off, good education combined with good techniques to reduce nociceptive input, you actually can activate that part of the brain that does not work well in people with chronic pain conditions, including EDS. So, in this case, in an older paper, manual therapy was done initially only for biomechanical reasons, but this paper showed that manual therapy can actually, joint mobilizations, can actually give changes in the central nervous system. And in this particular study, it was a 20% better outcome. The picture, unfortunately, covers the text a little bit. 20% better outcomes if people also combined top-down with a bottom-up approach in mobilizations. But we need to be careful that we don't mobilize things that don't need mobilizing. That would be a lack of common sense. So, pain neuroscience education is very important. We need to understand what pain is all about, because once you have sensitization, pain is really not a good indicator of what you should and should not do. It becomes unreliable because everything you do hurts, therefore it becomes almost meaningless. So what's really important to succeed in therapy, to succeed in life, if you have EDS and a lot of pain issues like most people do, we need to figure out as physical therapists, how can manual therapy and exercise change the brain? And we know lots of methods that we can do that. As a patient, you should not anticipate becoming more pain when you have a therapist who actually understands how the brain deals with these pain issues as much as we know about it. Even in that area, we're at the shorelines of our island. We don't know everything, but we know enough, I think, to be meaningful. Do not worry about pain levels. Yeah, your pain may go up a little bit, but it's not a reliable indicator that there's something more wrong with you. And as clinicians, I would say don't always rely on the report of pain by a patient. That doesn't mean that we should ignore your pain, but I already know that most people with EDS have significant pain. That's why people come to our office and the offices of other people who are interested in that. But if you give it a pain of 8 out of 10 or 6 out of 10, I cannot compare those two pain levels between two different patients because it's your own individual perception. But it's always about balancing what do we do hands-on, what do we do exercise-wise, versus what do we do with actually changing the function of the brain and making the brain, in fact, less effective in listening to the input, the nociceptive input. The study that's actually not even in print yet, in the Journal of Pain, one of the major pain journals in the United States, also said that if patients could accept their pain, it will actually decouple expectations associated between pain intensity and physical activity. So a lot of patients, and of course that's very, very logical. Now I've had a few injuries in my life. I mean, I broke my hip a few years ago. We were all in Dubai. It was very annoying. I got hit by the taxi I was trying to get out of. It was really, really frustrating. And I must say, for a long time, I was like, I better not do that because it's going to hurt. I immediately associated my pain intensity with physical activity. And I'm a physical therapist who treats pain patients every day. I should know better. But nevertheless, if you can deal that, okay, I have pain, but that doesn't mean I can't move, it's going to work a lot better for you. That does not mean we need to ignore the pain. That's really not what I'm saying. Even in fibromyalgia, there's a relationship between physical activity and brain responses. Yeah, it becomes an active process. We need to balance these things out. So physically active fibromyalgia patients, and I think you can also write EDS patients, appear to maintain their ability to modulate pain much better than those people who decide not to move at all. Motion is lotion. That's not a term I invented, but I love it. Motion is lotion. You need to move. So a few things that seem so obvious. When I see patients in our clinics, I think you should always look for a therapist who are willing to sit down with you and set your goal and prioritize your goals. When I ask my patient from the Midwest today, what do you expect from me? What are your goals? What do you want to accomplish? How can we work towards your goals? Yeah, it needs to be patient-centered care. Not like in this picture, that's just a funny cartoon, I think, but it needs to be with the patient as the center of attention, not the physical therapist. We need to understand the context of your own story. As the slide said, never judge someone without knowing the whole story. You may think you understand, but you don't. And that's more than just taking a good history. You need to understand, what does this mean to you? What do you want to accomplish in your life? It requires the physical therapy to really demonstrate understanding of the patient perspective of the problem. Most patients, you may be looking the other direction like these seagulls. Most patients know a lot about what should happen and what shouldn't happen, but I don't think they always get enough credit from their healthcare providers. How's the problem affecting your life? Well, in EDS, it's somewhat predictable, but every patient is unique in that sense. We need to explore your expectations, your beliefs, your understanding. How do you deal with it? How do you cope with it? Are you passive? Do you sit down all day long? Or do you actually try to live a normal, productive life? What makes a big difference? How can we get you to that point? A lot of patients with pain become anxious. Anxiety is a big problem in pain. It does not help. Anxiety makes the brain actually more efficient in processing these nociceptive input and actually make the pain worse. A lot of patients become hopeless. I've tried so many different things and it just doesn't work. Well, maybe it's because the whole picture is not put together in the top down and top and bottom up. A lot of people are fearful. A lot of people are fearful to move. And yes, it does take a lot of courage of a patient to say, okay, I'm really going to do that. I see a lot of patients, and my colleagues in my office here, we have two other physical therapists, Dr. Sophia Maines and Dr. Michelle Finnegan. We see a lot of people with EDS. And one of our tasks always is to help people overcome their fear of movement. Because movement is the way to go, but it needs to be relatively pain-free movement. It needs to be so structured that, yes, you can do these things without hurting yourself every single time, because that will actually feed back into the brain and long-term potentiation gets worse. We need to do the opposite. And yes, you can have problems in your joints. 99% complaints about pain in the joints. You can have problems with myofascial trigger points. You can have problems with muscle imbalances. Now, very few EDS patients look like this fellow, but that's just an example. Even changes in the fascia and the skin. Now, the brain PT says, oh, don't look at the skin and the fascia. There is no problem in the fascia. Pain is in the brain, not in the tissues. But fascia and skin both have nociceptive endings. They can contribute to the pain. This is actually a picture of your fascia, what it looks like inside your body. Very dynamic tissue. You can have altered neurodynamics. Your nerves may actually be a little tight. A lot of therapists will give you neural stretches designed for nerves rather than muscles. Muscle stretching does not really work all that well for EDS because most of you are too hypermobile already. And when you try to stretch, guess what? You're only stretching your cartilage, your capsule, not your cartilage, sorry, the capsule of your joints, making the problem worse by creating more instability. So there are a lot of physical factors that are important. And if we want to look at what are the things that make it worse, at the same time we can say, what things would you like to do if this all works out well? But it takes a big commitment from the patient and from the therapist. There are biomechanical factors. Yeah, we need to take a look at that as physical therapists, like how do you actually move? How do you compensate for this hypermobility? What have you done to make it work for yourself so you can still get from point A to point B? And if it doesn't work, how can we help you figure out how to do it better? There may be environmental factors. A lot of people are sensitive to other types of inputs. That is also a sign of your nervous system being way too efficient. Of course, there are psychological impacts. I would be very surprised if people did not have signs of depression, of anxiety, maybe even anger. Like, why does this happen to me? Why do I have a genetic predisposed problem that gives me all these issues? Why would you not be upset about that? That would be very strange to me. So the psychological part is definitely part of the picture. We need to take a look at that as well. Cultural differences. There are lots of cultural differences. People, different cultures process pain differently, look at pain differently. A famous study done many years ago compared healthcare providers in the Boston region, New England, and how they dealt with Hispanic patients, and they compared them to healthcare providers in Puerto Rico, how they dealt with Hispanic patients in that country. And they also looked at how do patients relate to their doctors. Well, there was significant difference, although the behavior of the patients was pretty much the same. Patients would present their pain in the same way, but the doctors in New England often would write, subjective complaints cannot be verified with objective findings. The doctors in Puerto Rico never wrote that. They understood that part of the Hispanic culture in that particular setting was that you are a little bit louder about your pain. You let the whole village know because people can pitch in and help you. Well, in New England, that was not acceptable behavior, but the behavior of the patient was the same. So different cultures, different religions, different customs, we all have different ways of dealing with pain, and we have to understand that. I mean, Henry Ford once says, life is a series of experiences. Each one of us makes us bigger, even though sometimes it's hard to realize this. Yeah, we need to move forward. We need to go on in life. Yeah, there's maybe some expert clinicians can deal with that, but we also need to be willing to look at the edges of the shoreline of the island to get to that. So hopefully that makes sense to you, that physical therapy should be a lot more than just biomechanics. Understanding how the brain processes information incorrectly with way too much efficiency is the reason people have pain, people have chronic pain. So I know there are different perspectives on this, and I think it makes sense to take a quick look at some other clinical experience that are being promoted as well. Yeah, stop and think. Yeah, it makes you stop and think, doesn't it? So we need to look at how do people deal with that? What other things are being done? Now, I read a lot of literature, and I write a literature review column for a medical journal every quarter. And I see a lot of things in EDS also, and in other patients as well, where therapists look at perceived asymmetries and pay a lot of attention to that, imbalances, misalignments, postural deviations, without realizing that most of those are really normal. There are no symmetrical people in the world. Everyone is asymmetrical by definition. We only have one heart. We don't have a heart on the right and the left. So by definition, we all are asymmetrical. So a lot of the common musculoskeletal pain complaints, you cannot say, oh, that's because you have a little bit of curvature in your spine or scoliosis. We can't say, oh, your left shoulder is a little bit higher than your right. That's why you have pain, even in many cases of EDS. Pain complaints cannot be explained solely by biomechanics, by structure, by deviations in structure, or by posture itself. I think a lot of people still make that mistake, but I think that's really based on outdated perspectives. The fact is that a lot of the tests that orthopedic doctors, physiatrists, physical therapists, chiropractors, occupational therapists, a lot of the tests we do have no diagnostic validity. And that's very frustrating. Yeah, so you see here a few examples of shoulder, some headlines of paper, of studies on shoulder pain. Yeah, they all show there is no reliability to almost any of the tests that we all learned in physical therapy school. So most tests for the shoulder lack sensitivity and specificity. So we can do all these tests for the shoulder, orthopedic tests, but as we outlined in our textbook, they are not reliable. You can't draw a lot of conclusions from these tests. The same is true of almost any joint, like the sacroiliac joint. There are no reliable tests for the position of the sacroiliac joint, even in patients with EDS. Yeah? The validity of a clinical test can be defined to the extent in which the test actually measures what you think you're going to measure, and most orthopedic tests fail the validity test. So, as we outline in our book, there are only 4 tests for the sacroiliac area that combined give you some kind of meaningful reliability. Each one by itself doesn't really mean all that much, and there are numerous studies that have validated, can you palpate asymmetries in the spine, in the sacroiliac joint? Can you palpate motion? In non-EDS patients, the motion in the sacroiliac joint is 2-3 degrees. That's it. No one can palpate that. So there may be asymmetrical positions, but they're probably due to local muscle forces, which give the illusion that the sacroiliac joint is out of place, or the shoulder, or the hip, or the knee, or whatever. But the SI joint most definitely is not possible. In the shoulder, there's only 3 tests, you see them here, that combined as a cluster of tests. That's what people do now when we realize, none of these tests by itself give you anything useful information. What if we combine a few, then we then get some kind of meaningful test? So clustering of these tests may provide actually better diagnostic accuracy than each test by itself. So in the bottom of your screen, we can't just look at anatomy, mechanics, and structures. We have to look at the whole picture and look at all these things of what actually happens with the brain, with our central nervous system. But the other phase is not true either. We can't just put our head in the cloud and just look at pain issues without looking at the mechanics of it. We need to do top-down and top-bottom. So an appropriate application of biomedical clinical knowledge is important. I love this quote: knowledge is knowing a tomato is a fruit, wisdom is not putting it into a fruit salad. So even if you think biomechanically there should be something, that doesn't necessarily mean that you have to address it the same way you would address other fruits or other mechanical problems. Doctors, therapists often tell patients things that are just not true. How many times have you been told that someone has a slipped disc? Well, let me tell you, discs don't slip. That does not happen, ever. Just like SI joints don't have upslips or any kind of other things. That just does not happen. So an upslip, as you see in this picture here, where this side is supposed to be higher up, maybe this side, the pelvis, is bigger. An upslip really does not happen. There is not a single biomechanical study that shows that it actually happens, and that manipulation can and will change the position of the joint surfaces. That has never been demonstrated. So joint mobilizations and manipulations, especially manipulations that are a little more forceful to correct stiff spinal segments, I highly question whether that's what we should do with EDS patients. I don't think that's smart unless there really is a sufficient reason to believe that you're going to change the function of the brain. If hands-on therapy is just meant to correct asymmetries and balances, I think its value is very questionable. If you do it as part of a bigger therapeutic construct where you look at top-down and bottom-up therapies, it can definitely be helpful. Just like ergonomics. This I just threw in at the end. We're almost done with this talk, and then we'll take some questions from you. The best ergonomic chair is only as good as the person who sits in it. Yeah, this is a nice chair, but do you think it really is going to make a big difference in this individual? Now look at this chair. This little boy has perfect ergonomic seat. The dog doesn't seem to mind. The boy sits up perfectly straight and can focus on its task. Yeah, and there are lots of ergonomic modifications, and they're great products that we have for EDS patients. And they're great. I highly recommend many of these products, and you can buy them at the different stores, but they're not the silver bullet either. So in conclusion, I think we need to focus in physical therapy also in making the brain chill out a little bit more. We can give people really boring exercises that don't really help, or we can give them really fun exercises. This is the topic of my first talk a few months ago, last year, I think even a year before, I forget exactly when it was. Make it fun. Do hands-on stuff that actually makes the brain function better. That's really where we want to go to. If you do that, Adrian Law in his case report would show that after that kind of physical therapy, where you have indeed therapeutic pain, neuroscience education, and some of these hands-on techniques, look at the MRI of the same patient now. That pelvic tilt does not cause the whole brain to light up anymore. There's still a little bit of discomfort, as you can see on the right-hand side, but it's much, much, much better. And that really is the key. Physical therapy should be comprehensive, top-down, and bottom-up approach to be successful. And that's really where I am. So at that point, I am ready to take your questions. How's that?
Thanks, Jan. Wonderful presentation and very entertaining as well. And I want to encourage everybody to be sure to watch part 1 of his presentation also, which we'll have a link to that from the video that will be on his page that you used to log in tonight. We're going to go ahead over to the Q&A box to see what questions we have from the live attendees tonight. Yeah.
Very good. I have one question here, if I have any thoughts on EDS and POTS for the treatment. So POTS is postural orthostatic tachycardia. Very common. We actually have a lot of patients because the combination is very common. When I see patients with EDS, I often wonder, how many modules do you subscribe to? And I don't really mean that literally, of course, But some people with EDS are just hypermobile, and they may have pain. Some people with EDS also have POTS, as an dysautonomia almost, like they get up too quickly and they tend to faint. So the combination is very, very common. What's interesting, what we have found with several people with both, that even if people have POTS, they can still, when we give them an external focus to focus on during exercise, they can go up and down rather quickly and they've never fainted. So I do think that the two go hand in hand. Dysautonomia is also a hyperreaction of the central nervous system, maybe a little bit more of the autonomic nervous system, but they're very tightly connected. So I do think that they come together. When people have POTS, we need to be a little more careful that we don't put them in positions where they would actually faint. That's not the idea. Similar question of a slightly different question. What is the relationship, I read the question, between pain and muscle spasticity? Does the pain cause the spasticity, or does the spasticity cause the pain? And what are the best ways to release this? This is an interesting question, and I don't really think that it's true spasticity what we see. Spasticity is a really particular problem with muscles that you see in cerebral palsy and with stroke patients. Most people with EDS do not really have spasticity. They just have muscle contractures. They have bands in the muscle that become very, very tight. The question is, which comes first? That's a little bit like a chicken and egg question. I am inclined to think, but I don't know that for sure. I'm inclined to think that EDS patients have more contractures, more of these taut bands than people without EDS. And in this coming year, 2017, we are actually planning a study with Dr. Frank Romano in Baltimore, Maryland, to actually look at that. Is that more common in people with EDS than without? My clinical experience says yes, but again, I don't have evidence yet. I'm still on the shores of my knowledge island. I'm inclined to think that the hypermobility came first. The connective tissue disorder is what people are born with, and that the muscle tightening, this what you call spasms, and not real spasticity probably, but these muscle spasms, these muscle contractures happen as a result in an effort to create stability. So the patient I mentioned, was he in less pain with the dislocated shoulder than with the spastic shoulder? That's a great question as well. And how do you make that call for what's right? That's really, really difficult. That's one of my biggest challenges. I never forget a patient I saw several years ago. She was in her 40s or early 50s maybe. I forgot exactly how old she was. She dislocated both her shoulders, and I did pretty much the same thing for both sides. And her right side, which was a dominant side, totally worked like a charm. It was fantastic. Her left side didn't get any better. I did the exact same thing. I wish I had a barometer or a thermometer that I could just put in the tissues in the muscle and said, okay, what do we need to do here? How much do we need to release it or not? It is always a fine balance, and there really are no good guidelines for it. To release the muscles, I think you have to do it very carefully. Don't release everything at the same time till you know how the patient responds, and because you do not want to create more instability. That is a big question. I have a next question here that says, any suggestions on equipment in the clinic for training EDS? Well, to me, the equipment is not the most important thing. I think it's important to have what we call an external focus. So rather than telling patients, oh, make sure you do this, make sure you do this, keep your body in midline, don't extend your arm all the way. That's all true and good advice, but once you start focusing on the body, you really can't do the task. Because all you do at that moment, you train your brain again to focus on pain. So rather than taking the attention away from pain, like being obsessed, being enslaved by pain, when you say, okay, make sure you don't extend your arm, make sure you tighten up your core muscles, you basically re-emphasize, brain, I want you to focus on pain. And that's exactly what we don't want. So I think an external focus is much more important. And we can create the circumstances that people do activities that are helpful, that are strengthening, that are pain reducing, that are dealing with the brain, without necessarily having to tell the patient that, without emphasizing that, but still create a circumstance that patients automatically would correct. On our Physio Fitness website, we have some videos. You can take a look at those where you see a patient with POTS and EDS hitting lights with a stick. That machine is developed for karate and for fighting sports. That's not what we use it for. But as she's doing that, her focus is on knocking out these lights as best as she can. She is standing on a very unstable surface. We never told her, make sure you tighten up your knees and your hips and your buttocks and your belly. We just said, how fast can you knock out these lights? The brain now is forced to focus on the motor function rather than on the pain. And we really, by doing that, train the brain not to focus on pain. So the equipment itself doesn't matter. We have very nice equipment. We have a wonderful facility, but that's not the most important part. The most important part is the orientation. We use very low-tech tools as well, very simple things. I always look at physical therapy shops and conferences. I always look for simple little things that we can create a little different. We actually have a surfboard that was featured in Shark Tank. Not a fancy piece of equipment, but if you look at one of these videos on our website, you see that that same patient with POTS is standing on that just playing badminton, while her brain is preoccupied with motor function. So I don't think it's the equipment that counts the most. So another question actually from someone I know very well. So thanks, Jan. In general, how often do you follow up with your patient that travel a long distance to see you? Great question, but that varies a lot. It depends a lot on the resources of patients. If they have family in the area, it's a lot easier. But my clinic is in Bethesda and the other one is in Rockville. Bethesda is not known to be the cheapest place in the United States. Hotels tend to be quite expensive, so if people need to stay in hotels, it's not that easy. It is sometimes not simple. What we often recommend, people come here, we get an assessment, we get a sense of, okay, what are the issues, what do you want to accomplish? If people can handle it, they come back usually a few weeks later. They may stay a week or 2 weeks, whatever they can handle. Of course, they have responsibilities at home, certainly if they have families, so there's a lot of factors to consider. We start the training and then people go back home because there's other needs that need to be met as well, and maybe a month later, 2 months later, they come back for another period. And we really try to give them ideas. What can you do at home as much as you can? So it really depends. I mean, we had 2 years ago, we had a patient here from the Middle East. He was here for 4 or 5 months in a local hotel. Finances were clearly not an option for this individual, and he waited as long until he was happy enough that he could restore the things he could do. For most people, that's not an option. So let's go to a few other questions. We still have a few more minutes. That's great. I'm not sure I can get to everyone. But we'll see how far we get. If nothing else, you can always email me, and I'm happy to focus on and reply to your questions also later after this webinar. How important is correcting forward head posture in alleviating upper neck pain and headaches? I do think that is important, but if it's that the only thing one does, it's not going to work. Yes, if you have forward head posture, you need to look at why do you have that. Are you sitting at a computer all day wearing bifocals and therefore you have to cock your head backwards to be able to read the screen? Or is it just habitual? Do you not have the muscle strength to sit upright? So just telling patients put your head back is not going to work. You need to assess what is the reason you're not able to keep your trunk underneath your head. Like, why does your head fall off? Are your neck muscles that weak? Are you in pain when you bring your head back? So I do think it's important, but just correcting posture by itself, I don't think it's going to be the problem. Okay, let's go on to the next question. And again, if my questions are answered too short and you want more information, feel free to email me. I'll be happy to reply to your questions in writing, or we can set up a time that you can call and we can talk on the phone as well. I'm happy to do that. Question here, if an EDS patient has a muscle imbalance near the SI joint on one side is passing or tighter, can that be relieved by manual therapy, dry needling, or another treatment? do you see this in EDS? Yes, we do see this. That's a great question, actually. A lot of people have muscle imbalances. A lot of people with low back pain have muscle imbalances. And they lead to probably incorrect input into the spinal cord and certainly can help contribute to the pain. So we can treat these muscle imbalances as part of a greater, bigger program, more comprehensive program. I mentioned I teach dry needling courses, so I'm inclined to use dry needling a fair amount with my patients. But dry needling itself is not the silver bullet either. Nothing is the answer to all the questions. So you always have to do this as a comprehensive model, and then it's actually quite useful. And many times it's very helpful to include that as well. I tend to use dry needling because it's easy and it's manageable for most patients. And in spite of the horror stories you heard, that's all that painful. You really don't have to do all that much to deal with that. There are a few risk factors you have to be aware of, but it's very manageable. The risk is very, very low. There's one question I don't quite understand about low entry level cost of equipment. I'm not sure I understand that. But let's take a look. This is a long question here. So let me read. I saw a PT, very experienced with EDS, who identified several SI joint dysfunctions, upslip included, instructed in manual techniques to encourage better alignment over a few months to adhering to these along with daily target exercise to stabilize the area have given very significant benefit. Great. Specifically after the muscle energy technique is applied to encourage correction of the upslip, I can feel an even distribution of weight through both legs and feet, where for many years the worst side, which displayed functional leg length discrepancy prior to this regimen, were quite a lot more than its half the loading standing walking. If you don't think SI joint malalignments like upslips are truly contributing factor, what do you think would account for this? I was actually afraid someone would ask that question because I kind of put my foot in my mouth, of course, when I said that. I have no doubt that approaches like that can work. There are many, many different ways you can approach problems in the SI region or in the back itself. In spite of, I was taught that too. I have done a lot of manual therapy courses and I've learned about upslips and all that. But if you look at the current literature, there really is not a single study that supports that. But patients still get better. The patient who asked this question clearly has seen a significant change. I would argue that it's probably a change in spite of the diagnosis of an upslip. I have no knowledge of whether upslips would occur in EDS patients. Maybe they do a little bit more because you're hypermobile and more in general anyway. But the manual work that's done, the corrections, muscle energy techniques, where you use muscle contractions to create more stability, I think do work, even though the reason why we do think may not be the real true reason why that is. So I have to look at high-level science studies where they've looked at very detailed studies where they look at can the SI joint actually move this way or the other way. Not a single study has shown that it can, so I'm inclined to say, well, it may be because of some other reasons, but it's probably just the fact that you're exercising, that you daily targeted exercise. I think that is important. If there's instability, you should do exercises that actually address that and cause more stability. Okay, I hope that answered the question. If not, please feel free to contact me directly, as I said before. We have time for one more question. It's actually 9:30, but there's only one more question left, so I'll get to all of them that you have offered. How does a patient they provide determine when the pain sensation signal is from sensitization versus possible tissue damage? For example, subluxation or dislocations. Of course, EDSs can overdo activities easily and injure easily. How do you find the balance in moving enough but not too much to injure or increase pain levels? Do you find that this is challenging for your patients? Well, I thought it was one question. This is probably 4 questions. But let's take a few seconds to digest that a little bit. How does a patient or provider determine the pain is from sensitization versus possible tissue damage? That's a great question. If there is a dislocation, certainly if it's forceful, if it's habitual, happens all the time. I have patients who can just pop their hips in and out. I am quite sure there's not much damage in that case. If it's traumatic, after a fall, after an injury, maybe whiplash injury, then you have to much more consider whether it's traumatic and actually has an issue of tissue damage. If it happened a long time ago, tissue damage is not an issue because the tissues have healed already. So you have to also look at the timeline. How long ago did this happen? Is there a problem? Is there trauma or is there no trauma whatsoever? EDS is easily overdo it. That is absolutely true because it's hard to know what you can do and what you cannot do. How do you find the balance? The best way to do it is trial and error. And is this challenging for a patient? I think that is the most challenging thing of exercise. The gentleman I saw today who said, I want to do these things. I want to live a normal life. He's in his 20s. He's probably listening to this now. He said he would. I told him it's going to take a lot of persistence. Just like the previous questions, I do a daily regimented exercise program. That's what it's going to take. You have to work a lot. It's not going to be easy. It is a tremendous challenge. I can also tell you, though, in closing point here, those patients of us who have taken it up, who said, okay, hey, yes, I can do this. I'm going to do this. I'm going to spend all my energy on actually getting to move better, figuring out how to do that. Those people generally are very successful at this. We've had, unfortunately, a few people with EDS who could not handle the stress of persistent exercise, of continuously changing your brain, of challenging yourself and how to do that. And I don't really have a good answer for those patients other than what is the reason you can't change? What is the reason you can't do that? Maybe there are other factors we need to take a look at. So I hope that answered your question reasonably well. Of course, it's always a little bit quick. I have a whole lot of questions in front of you, me, and try to answer them as best as I can. So I'd like to thank Dan and John one more time and all of you for tuning in and listening to this, whether now or later in the future.